All right, it's 3:31, so be respectful of everyone's time. We will go ahead and get started here. I want to welcome everyone to our presentation and question and answer forum with Dr. Chris Eberlein from Gunderson Health System. Dr. Eberlein is the emergency physician over at Gunderson. He's also medical director for Tri-State Ambulance, along with several other EMS services. He's been one of our local experts in the region during the COVID pandemic and on the front lines. He's very versed in the virus, the vaccine, and he's going to have a nice presentation for us to kind of go over the ins and outs, and then he'll be ready to answer your questions. So once his presentation is done, we will open it up to questions. Please feel free to go ahead and type those questions in the chat, and we will go through each one. Otherwise, if you would like an opportunity to talk to, via your mic and voice, we can do that as well. So without further ado, Dr. Eberlein, welcome, and I'll turn it over to you.
All right. Well, thanks, Kevin. Glad to be here. Can everyone hear me okay?
Yep.
Okay. So I'm going to start sharing my screen here, and I'm just going to jump right into the PowerPoint, if that's all right. All right. Can everyone see this?
Yep.
All right. I'm going to make it a slideshow. How's that look? Good?
Great.
So we're just going to start off, and we're just going to cover a little bit about where we're at with COVID currently. All right. So first off, this is Wisconsin numbers only. So we are at over 7,473 deaths is where we're at right now, with 29,000 hospitalizations directly related to COVID. As you all are aware, the economic cost, the cost for education for our students and throughout all age groups has been really astronomical, something that none of us have ever seen. We've seen increase in opiate deaths directly related to this. We've seen suicides and depression go up, especially amongst our youth. And we've seen significant cares and routine care, and delays in things such as cancer screening and all that. We're going to be digging ourselves out from some of that for some time in the future now. So for those of you, a little biology background here. So viruses are neither living nor dead, and they require a host for all the host metabolic machinery. And really their purpose is just to replicate. And that replication, unfortunately, leads to destruction and lysis of that host cell. And I'm going to show you kind of what that looks like here. So these are 3 Xrays that we, normal on the left. See if I can use a pointer here. So we've got normal on the left, smokers in the middle, and then on the far right is a COVID patient's lung. So you can see, so on the left, all that black area around the heart in the middle is normal lung. Lung is pretty clear. You don't really usually see a lot in the peripheral of the lung. And when you come over to the smoker's lung, it gets a little bit cloudier. And then the COVID lung, you've got all sorts of debris. In fact, you can't even make out the heart very well in the COVID lung because it's so destroyed. And this is the same sort of imaging of a COVID lung on a CT scan. So these are cross-sectional. Can you see my pointer?
Yes.
You can. Okay.
Yeah.
Okay. So this is the mediastinum. This is actually your trachea here as it divides. This is your heart, and then the lung on the outside. And so you see all this, it looks like debris in the lung fields. This is what COVID looks like on a CT scan to the lungs. And you can see all this. Now this is looking from the side of the patient. So these are vertebral bodies in the back, your diaphragm and your liver here. And this is all debris and destroyed lung tissue from COVID. And this one where you're looking straight on, this is the bronchial tree coming down, branching. And all this is debris and destruction of the lung. So you can see why it can be so hard to ventilate and why these patients have such difficulty breathing. It always amazes me is that they can have this much lung destruction and their oxygen saturations are really low, but they don't actually feel like they're short of breath. And so this is a post-mortem of a COVID lung. This patient ended up getting a transplant. They took pictures of it, but this is healthy lung and this is COVID lung. It looks very much like my anatomy classes in medical school, what smoker's lung or farmer's lung and the coal miner's lungs look like. And that's one of the reasons what we found out early on is that if you lay patients on their stomach, which makes it very difficult to care for them, it can help aerate those lungs because it tends to settle in the back of the lung. And so you're able to get some more, to ventilate patients easier. So when you hear about patients being prone, this is what we're dealing with in the ICUs. And fortunately, our cases locally have gone down, but that is what we've had to do with patients to be able to manage their care. So a few things about COVID, we know some long-term effects, but we've only been dealing with this disease for a little over a year. And so these are some of the known long-term effects of COVID that we're sitting on right now. Where people describe a brain fog that can last for months. They can get chronic chest pain. The loss of taste and smell sometimes doesn't come back. And that to me is interesting from the standpoint of your taste and smell are nerves that directly go into the brain. And so when you're losing taste and smell, this virus has actually significantly disrupted one of the major nerves directly into the brain. And we have been seeing blood clots in patients all along with COVID. Early in the disease when they're acutely sick, and after during their recovery phase too, we found patients with blood clots in the brain, blood clots in the legs, arms. They've had increased risk from inflammation and heart attacks and stroke. So the blood clots have been a big deal with COVID all along. So here are some other very serious effects that we found, is one of which is inflammation of the heart. And we've been seeing that with children, unfortunately. Go back here. Kidney injuries, a lot of that's from blood clots actually forming in the kidneys. Patients have had strange rashes, sleep problems have been ongoing, and depression. And unfortunately, we don't even know all the effects that COVID is going to have on the human body over the next years to come. So this is what we've been dealing with. So early on, we started donning all this PPE. We've been negative pressure rooms, changing our surge planning, facilities management and cleaning, turnover of rooms. And I leave this X-ray on there just because, we've had patients that have had zero symptoms that come in with non-related complaints, like this patient came in with a broken arm and turned out to be COVID positive. And had all of our staff not been wearing their PPE, we would have all been exposed. So, so that asymptomatic carrier or illness state definitely is a real thing. So we found this out because we were screening patients before they go to the OR, and we were surprised at how many patients were popping up positive with COVID. So what can you do? We all know wearing a mask, getting outside makes a huge difference. Not being around people when you're sick, and just keeping yourself healthy, rest, exercise. And third of all, get your vaccine. And that's what we're going to talk about for the rest of the talk here. So we've been fortunate to have vaccines since about the 1800s, when they first started realizing that our immune system can recognize things and have memory to it. And one of the things they found out was cowpox would give you immunity to smallpox. And so people would actually expose themselves to cowpox and you'd have some immunity to smallpox. So that was kind of the first hint that there's this cross reactivity. And then with the development of vaccines, we've eliminated smallpox. And if you talk to older generations talking about polio and measles, mumps, rubella, all of these diseases that we rarely hear of now, that is all due to our vaccination process. And quite frankly, I think it's probably saved hundreds of millions, if not billions of lives. And it is truly a remarkable achievement that we've been able to do for public health. So vaccines normally took years to develop. So one of the things they had to do is, the old way is you'd grow and weaken a virus, and then you'd inject attenuated or weaker virus into the body. So you would get sick, but not sick enough to harm you was the hope. And you would remember that virus, and then you would be immune to it. The trick with that is you had to develop that weakened virus, and then you oftentimes had to grow it in chicken eggs, kind of like what we do with the flu. And it had to be very stable. And fortunately, most of these viruses were stable enough that we could transport to clinics around the world and do the injection. But then came our RNA vaccines. Now, this is not an actual, they're new, but they're not as new as people were talking about. So they've been working on messenger RNA vaccines since 1980. And the first one that they started looking at was actually at UW-Madison. So the beauty of this, this vaccine is that there is no pathogen. So what you do is you take a strand of RNA and you inject it, the messenger RNA. It doesn't go into the nucleus. It gets translated into a protein. And what they were using was the spike protein that was so prominent on the COVID virus. And so they were injecting this messenger RNA that coded for that spike protein. It would get translated into just the spike protein. So there wasn't enough of the virus to make you sick or to do anything else, but you would make that spike protein, and then you'd made antibodies to the spike protein, which that antibody then flags when you get exposed, it flagged that virus for destruction early on. So you develop that immunity. So with this new messenger RNA vaccine that, like I said, they've been working on since 1980. One of the things they've been using it for, and there was other trials for that messenger RNA for other things, but with COVID, it really accelerated it. And it actually, out of all the things that COVID has done, this might be a true silver lining, and it might be truly a revolution in how we vaccinate. Because with that, when you think about this, is they knew the DNA, the messenger RNA of that virus within 2 or 3 weeks after we identified the virus. So once you get a platform to do this, theoretically, you could make messenger RNA vaccines over the course of months, not a year or years, which is really profound. And now that they've figured out the process, because before the trick was messenger RNA vaccines, they were so unstable. Messenger RNA is really like a secret message where it self-destructs very quickly. And so it was so unstable that you weren't able to utilize it before. And the whole trick to this was developing the carrier proteins and molecules that were around it, so that we could actually make them stable enough for usage. So the adverse events that we've been seeing, most of you have heard of, we're getting pain at the injection site, fatigue, headache, chills. For those of you who've had your vaccine, I think just about everyone I talked to have had, they felt a little off for a day or two. We're not seeing a lot of allergic reactions, about 2 per 10,000, none of which locally have had to been hospitalized that I'm aware of. So things have gone pretty well with the messenger RNA vaccines. Now, the Johnson & Johnson vaccine's been in the news a lot lately. And so what they did there, this is more of a traditional type of vaccine. And so what they were doing was they use an adenovirus. That in adenoviruses, we've been all exposed to. The common cold is caused by an adenovirus. What they did is they took a gene of the coronavirus spike protein, they inserted it into the adenovirus, and this adenovirus is weakened, and then they inject that into you, and then you make the spike protein yourself, and then you recognize the antibodies, and then so it's kind of, in the end, it's the same process, but the adenovirus vector is a little bit different. The nice thing about this vaccine that everyone was so excited early on was that it's more stable. So you had an adenovirus that didn't have to be stored at super cold temperatures, unlike the messenger RNA vaccines. It was much more able to be transported, and the really nice thing about it was a single dose. But they noticed that they were concerned that there was an increase in blood clots due to this vaccine. So they had 6 cases of this cerebral venous sinus thrombosis out of the 7 million doses. This is something that we do see occasionally, and the natural incidence is 4 per million. Now, when just to put this in perspective, the risk of a blood clot same type of blood clot or any other blood clot from COVID is 10 times the risk of that vaccine. So we're seeing about 60 to 70 cases of blood clots from the COVID infection itself. And there's a 1.8% fatality rate if you actually get the COVID virus. So like anything in life, there are risks and benefits. Now, they're not even totally convinced the vaccine is the cause of this. As you can tell, we're dealing with very small numbers, and to be in something that does occur naturally. Some of these patients have had a reduction in platelets that probably shouldn't have. So I think there may be definitely something to a risk for certain patients for this, but it definitely is not to the multitude. And I'm one that didn't think that they probably should have paused it for this incidence. There's a lot of discussion about that, but they did. And in the end, they restarted it, and they've deemed that this is probably not a high enough risk or even related is kind of what they're looking at now about the relation to that blood clotting. So right now we have vaccinated 4.2 million people in Wisconsin, and 31% of them are fully vaccinated. And, and we're talking 141 million people have had one dose nationwide, and 88 million are fully vaccinated. And of that, you're talking about a huge vaccination program, and we're not seeing large numbers of people that we're finding having sequela from the vaccine for sure. Nothing in orders of magnitude compared to what we're seeing with COVID. All right, so I'm going to stop right there. All right, so what questions does everyone have about kind of where we're at with the vaccine? And so the blood clot, male versus female, the predominance of the Johnson & Johnson vaccine, I'm assuming that's your question, Max? Is it Johnson & Johnson, or is it comments on blood clots in general?
Yes, Johnson & Johnson.
So there was a predominance of middle-aged females in that has been shown in the study. Predominantly, it was them that were getting it. Of the 7, I actually think all 7 were between the age of 30 and 50 female.
Do you have any insight as to why female are more prone to the blood clotting versus male?
Actually, females, we know hormones for one can increase your risk. So birth control is a known risk factor for DVTs. And I have not seen with these females on birth control, I'm not sure. So some of that stuff they're still teasing out. But you're also talking about such small numbers right now statistically that I'm not sure we'll ever really know. But I'm guessing it's probably because in general, we do see more DVTs and blood clots in female of that age compared to men at that age, for sure. And it's typically related to hormonal issues.
Okay, thank you.
Mm-hmm.
This is Dave Reed. I've had both of my Moderna shots, and I have been invited to, and I'm planning on going to Spain the first week in August. Mm-hmm. And I know we don't have an official vaccine passport or anything like that, but am I, other than just a mask, are there any other precautions that are being recommended for international travel?
Right now, I mean, this is a moving target, and it may change greatly by August. So right now, not that I know of, it's the masking after you're vaccinated. Your risk of COVID after being vaccinated is quite low, and especially your risk of being ill enough to be hospitalized. So that is good. And we're looking at, so far, we think that this immunity should last up to close to a year is what they're thinking now from the messenger RNA vaccines. We can't go out much farther than that because we haven't been given it long enough to know. But what we're seeing in cell memory of the immune system is it's looking very promising for longer term immunity to COVID.
So that was going to be my first question. Are we going to have an annual shot, or? What are you thinking in that regard?
Well, that is the $1,000,000,000,000 question, I think. Personally, I think that I mean, I'm very optimistic that we'll be one and done. But I'm not sure if this is going to end up having enough variants out there that we will need a booster to cover those. I'm fairly confident that the messenger RNA vaccines and the Johnson & Johnson should give us enough immunity for most of these vaccines. Most of the time, the immune system has pretty good memory for this stuff. So I'm thinking that this will probably get us through the COVID-19, this variant. I'm hoping that we don't get enough variants that it doesn't work against and that we need boosters for that. But I think that is the big risk right now, is that we end up with some sort of variant that we need a booster for. But fortunately, like I said, with those messenger RNA vaccines, we should be able to develop it fairly rapidly and not have to go through quite the rigmarole we did before. So transmission of vaccinated individuals appears to be extremely low, to the point that it's almost, almost zero is what I'm reading. It's extremely low, but there is that theoretical small chance. And so, and a lot of the mask wearing right now is from the standpoint that, we just don't know it that much. The CDC came out today saying that if you're 2 weeks out and you're outdoors and you've been vaccinated, probably don't need to wear a mask outdoors.
So the test that you do to determine if someone has had COVID, is that really applicable to somebody who has been vaccinated? I mean, if I were to go in for surgery next week and they wanted to do a COVID test in advance, what would they learn from that test?
Well, they're still looking for the people that may be asymptomatic carriers, and what they're looking for is active COVID in your nose, nasopharynx, because it goes back to, we don't even know what we don't know yet, and we're getting there and we're learning more all the time. But the concern is for staff and whether or not you are one of those, and we don't even know the numbers. Is it 1 in 1,000, 1 in 10,000, 1 in a million that could still spread it? We're still working on those numbers.
So my next question is this idea that you've had the COVID shot, and does that make you now like those people that were early on? Could, if you took their blood and put it in somebody else, you'd protect them? Or how does that work?
There's been talk about that, using their plasma, but not, we haven't really had to do that as much now, to be honest with you. One, it wasn't working as well because the variants it didn't work as well against. And our treatments have gotten better in general. So we have not been using the plasma transfusions like we did before. Haven't really had the need. So a couple other questions. Percentage of the population vaccinated that provide herd immunity. So what did I say? We're at 31% fully vaccinated in Wisconsin. The trick is how many of those have actually had it versus other people. And this is the real question, right? How many have natural herd immunity? We're still working on that. I am hopeful that once we hit like the 50, 60%, I mean, we're already seeing a drastic reduction in the La Crosse area. And we've done a really good job here. I think we're close to 50% now, last I heard. Like in the 70s of the people that are high risk of 65 and older. And I think that is one of the reasons why we have been doing such a good job with our hospitalizations and things like in our numbers, because I think that we are starting to push that envelope of herd immunity. I don't think, obviously we're still having cases, so we're not quite there yet, but we are hopefully approaching soon. And this is something else that I don't think, we've never studied, excuse me, a virus like this with the mass testing. I'm very curious to see, had we done this with the flu, how many asymptomatic flu people were out there spreading it? I think we're learning a lot about viruses and how to protect ourselves from them. And I think some of the things we're doing now will forever be with us. I keep telling I'm medical director for tri-state and EMS agencies. I keep telling them, we were so lax on respiratory personal protective equipment for years. And, it was not uncommon, some patient with a bad pneumonia in the back of the ambulance, coughing all over the place. Nobody had a mask on. They just brought them in, we all went in there without a mask, didn't mask the patient. I hope those days are gone. We should all be protecting each other and put the mask on the patient, wear a mask yourself, wear goggles. I, for one, the one nice thing, how many of you had a cold this year? I've heard from the pharmacists that they're not even selling cold medicine this year. So these things that we have done definitely make a difference on the other viruses that we deal with year to year. And I think that I think we've always underestimated how much cost and sequela from these other viruses were a burden on society. We just kind of underappreciated them. I saw it all the time, all these COPD exacerbations that get admitted to the ER, they were all preceded by these viruses, small viruses, would come through, you get a bunch of people in the hospital, COPD, the kids in the tubes in the ears. We're not seeing kids with ear infections right now, right? So, the poor otolaryngologists, their bread and butter, those tubes in the ears, they're not doing those procedures now. Those are costly. That's a huge benefit for all of us that are paying healthcare insurance and things like that. So hopefully we can continue to protect each other from these viruses and figure out a way to do that without wearing masks all the time, right? But hopefully in the future, when people are ill, it's okay to wear a mask if you have the sniffles, and hopefully it's okay to stay home from work if you're not sick. A lot of people are, it used to be, they just, either their supervisor or their coworkers, oh, you got a cold, you're not coming to work. What's wrong with you, right? I went to work when I had a cold, stuff like that. Hopefully that sort of thing is gone and we're more acceptable people that are, if you're sick, stay home. None of us want it. A couple other questions. Percentage of patients that test negative that have the virus depends on when we test you. We know that early on our testing, because the virus starts off in the face and the nasal pharynx, and then it drops down to the lungs. So if we test you in the first 1 to 2 weeks, especially the first 10 days of having the virus, it's very high, like in the upper 90s of us catching that virus and you turning positive. When it settles in the lungs 2 to 3 weeks down the road, that test drops off pretty significantly. And so yeah, so right now if you are actively sick with a cough and runny nose or sore throat, that kind of stuff, fever, the test is very, very good in the upper 90s for sure. One of the better tests we have. Those PCR tests work really well. Does the spike protein shed? So the spike protein it doesn't shed, it is part of that virus that is needed to latch to your cells. And it does not stay in the body. As you destroy it, you break all this stuff down. As if you get COVID and you beat it, you're destroying that virus as you see it. And so that virus that spike protein doesn't stay in the body, but your antibodies and your memory to it do stay. And we also know, and this was interesting about, it looks like our vaccines provide a longer immunity than the virus itself, than a native infection, which to me is very, one, surprising, and two, I think it's quite remarkable and tells you how good the vaccines actually work.
Dr. Eberlein,
Yep.
any new information on children under the age of 16 getting the vaccine, when that's going to be available, where they're at in the stage of that?
Yeah, they're in the final stages of reviewing that, is my understanding. I've got a 15-year-old who's playing soccer in a mask. I can't wait for the day that they can take those off and get vaccinated. I think we all, and from a medical standpoint, the difference between a 15-year-old and a 16-year-old is nothing, right? We really look at medically, we're talking, when I think peds, I think under the age of 8, to be honest with you. The physiology starts to get much more adult-like when you hit between 8 and 12. So I definitely think that we're going to see something in the next month or two here, probably even, I'm betting before the end of May. I think the Pfizer vaccine will probably be approved for that younger group. I bet they'll drop it to 12 is my first. I don't think they'll go all the way down, but I think we're going to see that next group of 12 and up get vaccinated. And I'm hoping it's sometime in May so we can get that age group done. Because right now, I think that's our reservoir, to be honest with you. And it's going to be, if we really want to eliminate this in our community now, I think we need to hit those kids and get them vaccinated and done with it.
Chris, I want to circle back to the messenger RNA. You mentioned that it could be a game changer because of the development of the vaccine. With the variant, I mean, is it my understanding that, let's say that, a year from now, a new variant comes out, based on what you're sharing, technically, all that would need to do is just to change the sequence of the messenger to combat the new variant. Is that correct?
That is correct. And the FDA has said that the thing they had to approve was that now that they've approved it, they were saying that the approval process will be very short because they've already approved the messenger RNA thing and the carrier proteins. And so if you're just changing that sequence, it'll be a quick approval. And Pfizer was saying they could do this. They could start rolling out a new one in just a couple of weeks. It would be very fast turnaround now that they have the process down, which, and it's not just for viruses. Some people are saying that this may be a game changer because we've often looked at the immune system for treatment of cancer and things like that, right? Because, it's scary to think, but we all have rogue cancer cells in us right now. And what keeps them from becoming cancer is our immune system recognizes that deformed or wrong cell and destroys it. If we could start, and that's actually where messenger RNA was being heavily studied for, was like a cancer treatment. That was that company that Pfizer coupled with was looking at it for that. Because if you could tailor someone's tumor with their messenger RNA and inject that and get the immune system to recognize that as foreign, it could be an amazing treatment for cancer. So like I said, this may be one of those great leaps in medicine. We just happened to stumble upon it during it was our solution to a pandemic, but it might actually be the solution for a lot more in the future for us.
And then just to piggyback on that, with the new variant in La Crosse County, I mean, there's some reports that there are a few cases of the new 2 variant in the county.
Yep, I've heard that too. It's not surprising though either. And fortunately, the vaccines do seem to work on the variant thus far. Some people say there's a little bit less efficacy with them, and I think that's probably true. But we're not seeing, hospitalizations from these people. I wonder if the variants and the decreased efficacy, you may be more likely an asymptomatic carrier is my thought, which kind of piggybacks on that other question about if I've had the vaccine prior to surgery and stuff, are they still going to test me? And part of it is because of those sorts of things. We just don't know.
I had a question related to vaccines. So in the beginning, I remember hearing a lot about different vaccines that might be available, Novavax and several others. But really, we haven't heard anything in quite a while. So I'm wondering, are these 3 effective enough? And that's why we're really focusing on them? Or might we see other vaccine become available as well?
I think we might see other vaccine available, but honestly, I think we happen to get with Moderna and Pfizer, the 2 stars of the vaccine. And then Johnson & Johnson with the ability of the 1 shot is huge because there's populations that are hard to get back in for a second shot. And that has been really beneficial for us to be able to do that. You probably read about in the paper when the family practice clinic went out and they did the unsheltered and they vaccinated them. How would you ever track them and get them back for a second vaccine? It'd be extremely difficult. And so the ability to vaccinate some of these higher risk populations that are in conjugate housing and things like that is really important. But yeah, and some of these vaccines, some of the other ones, quite frankly, they've had trouble in Europe with some of theirs. And so I think honestly, I think we were very fortunate in the ones we got.
Do you
So,
see this replacing the flu vaccine?
I would love, and this is my question. I would love to talk to one of these vaccine developers about, would this type of technology work to develop an influenza vaccine that is better than the one we've had? Because in the past, our influenza vaccine, that efficacy of the influenza vaccine, some years would have never made the bar for what they wanted for this vaccine. They said initially 50% efficacy is what they're shooting for. There's lots of years our flu vaccine is in the 40s, which is why you hear people say, I got the flu vaccine, I still got the flu. Well, that's because, only worked 50% of the time. So yeah, it would be phenomenal if, maybe they can get to the point where they'll be able to develop, the influenza virus is a little different, obviously, but is there a way that you could do this? Would be great. The one question that's on the board here, the vaccines are only emergency approved, and this alone leaves many hesitant to allow it to be taken. At what point does it go from emergency to approval to fully approval? Great question. At this point, I don't see it going to fully approve, because typically that they want to see years of making sure that they'll be reviewing this for years. Now, that said, we've given more doses of this than we have a lot of other things that have been FDA approved. And this is as safe as any other med that we're giving. And it goes back to everything's got risk and benefit. And I like to compare the vaccine to getting COVID, right? I mean, that's the bar, which one's better for you? Clearly the vaccine's better. You're talking, 1 in millions of side effects that are really bad. And even if those end up truly being related to the vaccine. So everything we do has a risk, right? We all took a risk driving to work today or going to the store. If you look at the risk and benefit, I think the benefit of the vaccine greatly outweigh the risks.
Dr. Eberlein, can you touch real quick on just the differences between the Moderna, Pfizer, and then the Johnson & Johnson one shot? We know early on the efficacy was in the high 60s for Johnson & Johnson, like 90s for the other. But just, I've still had questions where people ask, at what point can I pick which one I want? Mm-hmm. I want the one that's better, but, I think you did a good job last time of putting that in perspective for everybody.
Sure. So the Moderna and Pfizer are both the messenger RNA. They just used a little bit different carrier proteins and things like that, but they are both basically the same process and same way they work. And both of them are in the upper 90s of efficacy. But it takes 2 shots to get you there. The Johnson & Johnson, the last I read was 72%, so not as effective, but it's only 1 shot. And that was 72% at you getting COVID. It still was nearly 100% at preventing you from dying or being hospitalized from COVID. And, that was the goal all along. None of us, we were all in general okay with getting a virus that just made us have a stuffy nose and didn't feel good for a few days, right? That happens to us all the time. But none of us were really on board with the 2 in 1,000 chance that I might not come home from the hospital if I get hospitalized. So with having vaccines that actually prevent the death and the hospitalization, that was the goal all along. And all 3 of them do that. And all 3 of them reduce your risk of transmission as well. And your other question, Kevin, about when will you get to pick? A lot of it right now is just based upon geography and what is available at the time that gets shipped, right? For a while, even the hospitals didn't even know what they were getting. They'd find out Monday and they'd get the shipment on like Tuesday or Wednesday, and they didn't even know. So they'd actually have to adjust what they were going to do. But now as that supply chain gets more stable and the vaccine gets more abundant, and fewer people need the vaccine, right? Because we're getting, more people are getting vaccinated. That I think the day will come where for sure you're going to be able to say, well, gee, I'd prefer Moderna over over Johnson & Johnson. Or I prefer Johnson & Johnson because I hate needles and I just want one shot and I want to be done with this. So I think that that day will come, but probably it will be not till fall.
Great, thank you.
So former President Trump got COVID and they gave him some exotic medication to, is that readily available to you guys at the hospital now, finally?
Yeah, those are the same drugs that we've been giving basically for months now. Yep. It was fairly experimental when he got them, but it was that the therapy that we were given, you know, we've been doing it to keep patients out of the hospital for a while now. You'd actually come in if you had early on symptoms, you could go get an infusion and it would hopefully the plan was it would reduce your risk of hospitalization. A lot of these drugs seem to be really dependent upon the timing you give them. You had to give them either early on. Steroids couldn't be given early on. You had to wait until you were sicker to get steroids. So a lot of this stuff has really been fished out over the course of the last year. But you can see, I mean, our death rates in America and in our region are lower than internationally for sure. I mean, we've learned from others' mistakes. It's always good to be not the first one to get hit with a pandemic. You know, I mean, as it rolled across Europe and in China, there was the forums and threads in emergency medicine and in internal medicine and critical care were exploding with what those other physicians were seeing over there and their experience. You know, they were saying, oh, do this, don't do that, you know, so we learned a lot before it got here and got bad. You know, just like the whole don't put people on a ventilator, put them on really high flow oxygen. One of the reasons they were putting people on ventilators, I think early on in these other countries, was because when you're on a ventilator, if you have a filter, you're on a closed circuit. And so you weren't spewing the virus throughout the room. And if you're in a you know, traditional, if you're in a country that doesn't have the resources we do, and then you had multiple patients in a big bay, that would, if you didn't have COVID and everyone else was on high flow oxygen and nebulizers, you're getting COVID, right? Because it's going to be all over that room. Whereas there, they were just like, well, we can just intubate them. Then we can put a bunch of people in the same room and it's all closed. And then we're protecting their staff too. Well, it turns out ventilator management and COVID is the really wrong thing to do. And you're way better off on high flow oxygen as long as you can go.
So messenger RNA is like version 1. What will it be like when it becomes version 2 or 3?
So, well, they'll still
improve it.
Well, they won't improve it because the process is there. What they'll be able to do is take the RNA from whatever virus we happen to find that's plaguing us, or if this one changes a little bit, you'll be able to figure out if it changes its spike protein a little bit where our antibodies don't recognize it, we can just code that messenger RNA from that new spike protein and make a new vaccine out of it rather rapidly.
I was thinking more in terms of the freezer, you know, I mean, right now.
Oh, yeah.
You guys are paying big bucks for specialized freezers, right?
Messenger RNA vaccines are unstable. They've dropped I'm not, you know, eventually they'll probably figure out how to make it more stable with the carrier proteins and stuff. But even Pfizer, who had the really restrictive freezer requirements, has dropped it a little bit. So it has to be carefully handled and it can't get too warm and things like that. But it's a little bit more robust than they initially said. However, you know, we're fortunate that we had plenty of those type of freezers locally. I have a feeling that it will be a while before they come up with the messenger RNA. They've got something that works. I'm not sure if they're going to mess with it that much to find the room temperature version eventually, but I'm not sure how quick that will be.
This is David. I got one more question, please.
Yeah.
Earlier I talked about going to Spain. Have you had any, or do we have any data about how well other countries are beginning their vaccination programs and where they're going to be, how long they're going to be, that kind of thing?
Yeah, you can actually, I was actually looking at today, they had a big graph of, and I just was doing a Google search, checking my numbers. They had a big graph of the countries and how they rank in vaccine, how they rank in mortality from COVID and all that. It's pretty easily found if you just take a look. Where they'll be in 6 months, hard to say because everything's improving. You know, we're getting more and more vaccine, and as are they. So I'm hopeful your trip will go out with any hitch. Maybe you won't even need to wear a mask by August.
Just to kind of add to that, Chris, I mean, what are your thoughts about, with India and like the Brazil? I mean, you've seen on YouTube where they're burning bodies. I mean, that's pretty severe.
Yeah, no, it's a real disaster over there. And for any of you that have ever been to India or Brazil, you know, their healthcare infrastructure wasn't real robust. I mean, there was challenges prior to the pandemic. And, now you've got hospitals that run out of oxygen, right? You've got hospitals that it's not uncommon for them to say, we can give you that drug, you go find it, but look out for counterfeits. And so the family actually has to go out and find the drug themselves and bring it to the hospital, and they'll give it, not even knowing what they have. So these are real challenges in these systems. And unfortunately, when you get something like this, a pandemic really shows your weak points in your health systems, right? I mean, and we found ours. And if you've got bigger cracks in your system, it's really going to widen up when you get those patient surges. And unfortunately if you can't even put patients on oxygen, your death toll is going to be really high because they need it. A lot of patients needed oxygen for a couple of days here, but then they went home. And we were all set up to send people home with oxygen if our beds got too full. You know, if you only need a couple liters, here's an oxygen saturation, here's an oxygen tank. You go home and you call us every few hours with that reading on your finger, and if it drops below 92, you let us know. They're not even able to get oxygen for their hospitals in some of these areas. So, unfortunately, they're going to see a really high death toll because of that. And it goes back to the vaccine, like the other gentleman was saying about stability of the vaccine. You know, that is one of the challenges there, right? I mean, how many high, really low temperature freezers do they have? Well, not enough to support a Pfizer vaccination program, so they really need more stable vaccines for these other areas of the world, which is also a challenge for us too, because the longer this thing sticks around, the higher the chance it mutates a little bit and makes the other things that we're doing ineffective.
There's a few more questions in the chat.
Let's see here. Find out where we're at. Oh, there it is. All right. Any recommendations on the top 3 discussion points have with family in the higher risk, the uncertain to get the vaccine? So one, I would say that we've had several 100 million people in America vaccinated, and we are not seeing people having significant problems with this vaccine. 2, COVID's still out there, and if you're high risk, it could we're seeing people, and 2 in 1,000 are dying from it. And if you're high risk, it's much higher rate than that. So you really have to have that conversation at risk and benefit with them, and to let them know that, there's some people that they're so concerned about getting back to normal. Well, this is how we do it, right? If we want to get back to normal as a society, we got to get this vaccine out there, and we got to get people vaccinated so we can get back to normal. Some people reluctant. Is there a solution for this that predates COVID? Yeah, I mean, you've got anti-vaxxers out there that are always going to be there, and some people you're not going to be able to convince, unfortunately. It is interesting how some of the old anti-vaxxers, they were against polio and getting vaccine for them, but they were okay with COVID, which I don't understand. And then you've got other people that are okay with those that are against COVID. I've never seen a vaccine get politicized. Of course, that's kind of the culture we're in right now, unfortunately, in America. Seems like we can't not politicize just about everything. But hopefully we can get over that and people can start really looking at, one, the science and how do we protect each other and how do we, protect the ones we love in our communities. And that's what this is about.
And then just to add to that, we're talking not just our community, but we're talking globally, right, Chris?
Yeah, absolutely.
Because let's say if a country X overseas doesn't have the resources, or let's say they all are, vaccine shots, it doesn't help us to move forward.
Nope. Because, that'll be where the COVID 2020 starts, right? Mutate enough amongst them, and then it'll be here, and then we'll all be starting over again with at least hopefully we've learned enough, and with the potential for the messenger RNA vaccine, we could get ahead of it. But it'd be a revolving door if we don't kind of tamp this down globally.
You mentioned early on that the procedures that you're following with the ambulance service now are to use protocol all the time. I presume you're doing that in the emergency room all the time now.
Mm-hmm.
Do you see that law enforcement is going to have to do that in the future, that they're going to kind of go to most scenes with protective stuff with them?
Yeah, I mean, I think the days of anyone in public service approaching someone who's got a cough and a fever to not mask yourself or the patient is going to be hopefully days of old, right? If I was a law enforcement officer and I was approaching someone who's hacking away, I'd be like, here's a mask, let me put mine on, because I don't know what that is, but I necessarily don't want to get it, I'll tell you that. And it's amazing how much there's other things like C. diff colitis, where people get terrible diarrhea. Well, that's a stool-borne illness. We've seen less of that. Well, how do you beat that? It's not from the mask, it's from washing your hands. And so the community washing their hands more, these simple things really do make a difference. Listen to your moms as you were a kid. Go wash your hands before you eat, right? I mean, I guess this advice was what we needed to do all along.
Any other questions anyone has, or what a great discussion.
Perfect.
All right. Well, I want to thank everyone for coming and taking the time. This was fantastic. Dr. Eberlein, we cannot thank you enough. Number one, for everything you've been doing for our community and our region. It's been invaluable. But what you're doing for Western, for our students and our staff too, your presentations have just helped so much. And I've gotten so much feedback, I think we all have, and just how helpful it's been for not only them as a student or staff member, but then taking it home to their families and their friends and really disseminating that information. So again, we can't thank you enough.
Well, thanks a lot. And I hope this does help. We've heard that people really want to hear from local people that they trust, rather than, social media and things like that. So anytime I can do to help get good information out there, because that's really what it's about. I want people to make informed decisions with good information, not with information that they just hear from whoever. So, and thank all of you for hanging in there and taking care of our community too, because all of you are doing great jobs, and I know it's been hard on everyone. So hopefully we'll be done with this soon.
Yeah, we're looking forward to it.
Yeah.
All right. Thank you. And thank you, everyone. We appreciate it. Have a good evening.
Have a good night.
Thank you.